We are privileged to have with us this morning Dr. Chua Mei Chien, who is the head of the neonatology department at our large children's hospital. Mei Chien will be chairing this session. Thank you, Mei Chien.
Hi, good morning, everyone, and welcome to day 2 of this very exciting Asian Pediatric Ethics Conference. And it is a great pleasure for me to introduce our first speaker for this morning, who is none other than Professor John Massie. And I think all of you are familiar with him. He's the clinical director of the Children's Bioethics Centre at the Royal Children's Hospital in Melbourne, Australia. And yesterday, he delivered a very brilliant keynote lecture on the ethical challenges in children's healthcare. And Professor Massie is also a respiratory physician at the Department of Respiratory and Sleep Medicine at the Royal Children's Hospital in Melbourne. And he holds concurrent appointments as the Professorial Fellow at the Department of Paediatrics, University of Melbourne, and Honorary Fellow at the Murdoch's Children's Research Institute. So this morning he'll be speaking to us on a toolbox for the ethics of home ventilation for children. So let us put our hands together to welcome him.
My talk today comes from the perspective of working in Australia, in Melbourne, in an extraordinary medical town, and in a community that can support people at home on ventilatory support, essentially without much cost financially to them, but certainly lots of emotional and other costs. I'm not going to cover all of this because we did this yesterday, except to say that I think within home ventilation is really one of my light bulb moments about who I am and the sort of care that I want to try to deliver, and how embedded in ethics and ethical practice that it is. So for those not familiar, home ventilation are patients who might require support for breathing, usually because the breathing pump is not strong enough, with patients with various neuromuscular conditions or neurodevelopmental conditions. Sometimes people forget to breathe when they're asleep. Sometimes people have chest wall mechanical problems and some new problems in terms of lung diseases, such as interstitial lung diseases, occasionally CF, and now really for us chronic neonatal lung diseases, babies born prematurely who survive and for whom we can support them outside the neonatal intensive care unit and potentially at home. And the technology we'll talk about is both non-invasive through some sort of mask interface, and we're thinking of this, I think, of bi-level ventilation, so breathing in and having an upper pressure, breathing out and lower pressure, not specifically CPAP for this group, or it's invasive through a tracheostomy. And here are some of the considerations. So this is sort of the medical part that we do need to have our finger on for this. So patients might have sleep disordered breathing. They go to sleep. Breathing is vulnerable. We all breathe more shallowly when we're asleep, and if you're vulnerable and not strong with your breathing, it will be worse. But that might go into daytime as well and have daytime respiratory failure. Or for some of the patients we're considering, actually they might have that, or really recurrent atelectasis and respiratory tract infections for which they'll benefit from some positive pressure support. A really important concept is trajectory. Are these people who might recover? And then clearly there's not a lot of ethical issues there. People who are stable, this might be lifelong support. Where we really start to get into the difficult ethics is if it's progressive disorder or it's palliative. And we think, well, the comfortable end of life is one of the goals, but that might still include ventilatory support and might still include invasive ventilatory support. And then the other important consideration is the time on support. Is it just at night? Fairly simple, night equating to sleep really, although for babies, of course, that's not necessarily so. Or is it all sleep, so daytime snoozers, night and daytime top-up, or is it actually over 24/7? And those sort of requirements or the trajectory into those, I think, makes a big difference in the way we think about and how we might set our goals of care. But it's not as linear, is it, most of the time as you might think. And this is sort of a classic picture which Avina, one of our fellows who's done some work with us in respiratory support and also in palliative care, and particularly focus here on a patient with severe neurodevelopmental disability who is starting to fall into some sort of respiratory failure, and then there's recurrent infections, and then more frequent and more severe recurrent infections and a trajectory. And those patients with neurodisability, which is a big group of patients that we would support, it's not a static neuropathy. They're progressing both in their neuropathy and certainly in their respiratory pathway. So some of the considerations is when we're thinking about this is, can this patient get home? And the real consideration there, which I haven't highlighted, but is what is it about home? And if your poster's gone down, the bottom of that poster, which was a palliative care poster, it had this lovely line, "Home is where the care is." And so I guess that's what we mean by home. I have a bigger conception that home is a place where you live, it's a place where you flourish, it's with your family. But I'm not thinking that it's just ideally someone who just goes in their bedroom, replaces the wardroom or the intensive care unit, that it's a place where you can go to the lounge room, you can go outside into the garden, you can go out and about, you can engage with your community, you can go to school. So that is, at least in some sort of ideal, what home ventilation can mean and perhaps should mean. But I'm very conscious of the fact that our intensive care team at our hospital are often quite quick to want to put a trachea in a ventilator, and then the patient is out of the ICU, job done, a week later. They're on our ward for 3 to 6 months, maybe less, but 3 to 6 months. So ICU doesn't care. So their moral obligation seems to stop at the door. But I don't want it to think that my moral obligation stops at the door when they go home too. So we're not just sweeping this under the carpet and sweeping them home. We're hoping that going home has some real meaning for the child and the family. So stability, not having met calls and being able to manage whatever's happening at home. Is home feasible, of course, is a key question. So where do you live? So we have people who really don't have stable housing, but we can usually sort that out. So this often becomes a social issue, and I think that's a terribly difficult ethical question. Is you may have two families in exactly the same position with their child, but in different circumstances at home, and one family is able to make a go of it, another family. We've had a situation where a mother with no home to go to, a twin sibling and two other kids who are disabled. Now, how do you manage that, and how do you see that kid in their family or that kid with their own life and their own trajectory? And is this what the parents, but we always got to think about, we're often talking about parents because these are maybe small people or people with a severe neurodisability, but what does the child want? Concepts are simple, Carl. Practice is not necessarily so simple. So here are some of the people. We could have had lots more pictures, but just for those who are not familiar, baby on the top left there is on CPAP, so it's a nasal mask. Oh, he's not on CPAP, he has a nasal mask. That could be CPAP, could be BiPAP. Baby below has a tracheostomy. You can see it also comes with a nasogastric tube, not strict necessary always, but pretty commonly. It's hard to swallow with a tracheostomy tube in, and certainly ventilator. Sort of ventilator, it's a complicated piece of machinery, but the size of a large tissue box or old-fashioned telephone, if any of you are old enough to know what a desk sort of telephone looks like. But of course, there's a lot more going on, isn't there? Is that the baby below is actually showing you. And I think one of the questions is the home becoming the ICU or the ICU becoming the home, and that's really important to think about. But I love seeing the pram there, because it means that technology can help that baby get out and about. So let's anchor this in a couple of cases. Samira's 10, non-verbal, limited mobility, severe cerebral palsy, PEG fundo, increasing hospitalisations and PICU visits, and now prolonged admission. Someone thought we should do scoliosis surgery, but that's not gone as well. Complicated by respiratory infections. So what should we do now? I guess that's a great sort of Socratic question, isn't it? And I guess whenever people are using that word, there's ethics, there's your ethical moment that you're looking for. And Poppy's 18 months, and she has Pompey's disease, which is a congenital metabolic disorder associated with weak muscles. There is an enzyme that works reasonably well to try and delay progression, and particularly it's good, seems to delay progression of heart function. She has that severe progressive weakness despite this, increasing admissions. She's had a long ICU stay, airway secretion management, and parents demand active intervention, tracheostomy and ventilation. They know all about it. They're on the interweb. and they know, so what should we do now? So these are some cases we should just think about as we go through. So should we embark on home ventilation? So is this in the child's interest? That's where we'll be trying to think about, and then there's a whole lot of information, isn't there, we want to assemble to try and work that out, but it's the focus on the child. What are the limits of what we can provide, and are there limits of what parents can demand? And I think, not us, I don't think people in this room, but I think it's a very, very common question that needs addressing, is should costs and resources use influence willingness to provide long-term assisted ventilation? And maybe that's us, me from Melbourne, and Biography Hospital and society, maybe Singapore, but I know that you're very tightly engaged in a region where resources perhaps are far tighter and a far bigger issue. So I think, though, I'd like to debunk, at least from that first world perspective, about the costs of care, and not to dismiss that lower income country issues then. Cost of healthcare rising, we know, but it's not because we're supporting, just because we're supporting disabled children. And the cost can justify the treatment, but it might be the same arguments on both sides. Well, it's short term or it's long term, and that can be used as an argument for sort of both ways, really, so it doesn't do any work there. I think what's important is that the underlying issue for many when they talk about this is not about the cost, but it's about valuing children with disabilities. And I think that's probably, in a sense, where the money is, excuse the pun. And then, you know, maybe as a society, what sort of society do we want to be? Do we want to support our most vulnerable people? I mean, there are limits, there have to be, but I think these are really, really important considerations to have. So what's in the ethical toolbox? Well, we'll go through each of these. None of these is an individual concept, and you're familiar with them, or it does all the work, but there's work that we just have to. You're not going to build a house with a single tool. You could be an orthopaedic surgeon with a hammer, but the rest of us need a whole lot of different tools to do this sort of work. Just in case Scary Time Lady starts flashing messages at me down the back, if we get no further, this is probably the most important slide. This is a sort of cut through that one of our developmental physicians uses. It's extraordinary to get to the end of a complex meeting when you've had a meeting with the physician, you've had a meeting with the team, you've had an ethics consultation, and Juliana says, all very well, but what's in it for the kid? And there's a lot of ethical work in that simple cut through, but I think it's really, really important to just be coming back to this. And then, you know, I think, well, you know, part of it is what do we owe the child? I used to have, sort of not in the toolbox, but firmly out of it, was some slides about futility, sort of a little bit like the cost question, and I think that futility in the circumstances that I'm talking about today does any work. It doesn't help the situation. I think this is a really useful paper. It goes back a little while, but it just helps us when we're starting to talk about futility. What are we doing with these kids with severe delay? Is to actually, what we really should be doing is reframing things in terms of ethic of care. And that was actually, Daniel talked a bit about that yesterday. Sam, the koala, was very badly burned in the Black Saturday bushfires in 2010. He was quite shocked. He died a couple of months after this, but it was still worth having a go, and we still cared for Sam. So I think it's a wonderful picture. So, you know, in the toolkit is child and family-centred care. I think going back a little while, certainly at our hospital, everything was marketed up as family-centred care. It was this sort of great thing that the Children's Hospital did. But my critique of that was that it left the child out, and as we talked about yesterday, all too often the interests of the child can get sold out to the interests of the family or the adults, and maybe, I think, less so, but I guess there's the risk of the community. So a little bit like what's in it for the child, let's keep our focus on the centre here. I think goal-based approach has to be where we do a lot of our work, and there's a lot of things that are contributing to goals. We talked about our values yesterday, with the loose concept that parents might bring values, or the child, if they're older, what's important to them, and we'll bring physiological facts. But I think if those of you who've done some work like this, how just organically these patients sort of grow on us. Somebody's a bit sick, they come, you think they've got a viral illness, they get a bit worse, they go to the ICU, they go back to the ward, they go back to the ICU, they're on non-invasive ventilation, people talking about invasive ventilation, and next thing you know, 3 weeks later they're stable and they're ready, having some time off non-invasive ventilation, and they're coming back to the ward, and all of a sudden people are thinking about home ventilation, and it's all just happened, and really any goals that people might have had have been short-term goals. How do we manage this acute respiratory failure and get them to ICU and back, and the actual goal of what are we doing here, what's in it for the child, has actually been forgotten. And I sit in plenty of our home ventilation meetings, and I guess that's my job as a apparently senior person, I would say early pre-middle age, but you can judge differently. For me, is to say, what are we doing here? What's the goal here with these patients? And I think we just have to keep refreshing those goals, because the landscape moves and changes. And of course, the normative goals: what does the child and family want, and what can we do for this child? And of course, most of the time when we have conflict, it's that we can't really marry the two. There's sort of conflict between what the parents might want. And often it's we want everything, which is we want you to restore the health of my child, and it's just not possible. But can we make life better is really my very simple mantra, and perhaps we can. In ethics, it's often good to ask the other question and flip things around. So I don't know if you do this when you do your ethics consultations. And so this is a paper which just really talks about life not worth living, and it's really getting at what's quality of life, what are the things that people might think about when they're thinking about, is this a life not worth living? Because the flip side is this a life worth living, and therefore in the context we need some ventilatory support to help the patient keep going. In this paper they're trying to isolate some of the things that might really make a difference about whether it's obligatory to keep going with life-saving treatment or not to keep going with life-saving treatment. So the degree of a patient's awareness seemed to be very, very important. I'm often troubled by that, because sometimes the less aware the person is, then the less suffering they have, and the more aware, locked-in capacity to suffer could be greater. So, in some ways the arguments could be the same, but most people think if a person's completely unaware of what's going on, then perhaps life there aren't things to enjoy. And I do suspect sometimes the capacity to enjoy things and the capacity to experience negative stimuli, pain, etc., are not evenly matched there either. So you retain the suffering bit and not necessarily the good bit. Careful not to weaponise the word suffering. Possible awareness, harder to know. Minimal cognition might be important. Locked in, though, you might be locked in, not able to move, not to do much. This might be our little one, Poppy, with Pompey's at some stage. Relational capacities, the possibility of that person having some sort of meaningful relationship with those around them, and you see how that really shifts. And significant burden, which I assume, I couldn't quite remember from the paper, but I'm assuming is burden of treatment to the child. I'm not agnostic to the burden of the cares that the parents have to undertake, but it's the burden to the child that's the focus there. We talked about shared decision-making as an ideal, but it's messy. Yesterday, and this is quite a nice paper this is Muriel Gillick, nothing to do with Gillick competence, different person, different situation. And here Muriel is sort of trying just to re-engineer shared decision-making. It brings it back, interestingly, to goals of care, really, but a style that we might do is clarifying the patient's health status, being clear ourselves, and then actually understanding and communicating with the family about what they understand their child is facing or the situation they're in. Trying to elicit and prioritise patients' and parents' goals, but I think that's so mixed up in values of care, and then trying to map the two together. So I think that there's some utility in re-engineering shared decision-making very clearly back to goals to see what we're doing. In amongst all the complexity of eliciting those values in the paper we talked about yesterday, is a good read to think about. So we've had family-centred care, we've thought about quality of life, issues, shared decision-making. These are things in the toolbox. The zone of parental discretion is in our toolbox as well. So this is a concept that was developed by Lynn Gillam, who I work closely with, based on her reflections of how cases would go that we were involved with at the Children's Hospital. And while we work to an ideal of best interests, the reality is that's not always the place where we land, and that we want to try and preserve families, parents as the natural and legal decision makers. We recognise that a child will flourish in a functioning family, and that sometimes for various reasons families will not choose best interest of the child, and you could send one child to a private school because you think it's best and not have enough money for the others, and you've got to balance that. So parents are making these decisions in other contexts all the time. So really thinking that family might have to make a decision that's okay, plan B, plan C, and is good enough. And really what we sometimes get down to is the decision that the family wants to make, either we're asking them to make or they're demanding to make, is that harmful? So that's getting down to the harm principle that Doug Deacomer talks about, and Doug's paper is very, very helpful on that. It's not a fine line, but it's a bit narrower, and it allows the parents lots and lots of discretion. So I think we're sort of balancing two things here, aren't we? The interests of the child that I keep coming back to, because I think when we get into the zone, that's perhaps the weakness of the zone, that it just focuses on what the parents want far more. That's a very useful tool. Is this in the zone of parental discretion? We're thinking particularly for when parents are demanding treatments like Poppy's parents. So this is a book that Lynn and Ros McDougall, if you're lucky enough to be here last year, you would have met Ros, and Claire Delaney, who used to work with us, but is still wrote a couple of years ago, When Doctors and Parents Disagree. So it's really worth the read, and it's not terribly expensive. One of the chapters that I wrote in it, well, the only chapter I wrote in it, was about this situation when parents are demanding treatments that doctors think are burdensome, and I think with Poppy we might be thinking about that. So I think one of the things, is it addressing a treatment goal? Is there some legitimate goal that we agree on is useful here? And that may be the stumbling block. More time, is that enough? More time for the parents is super valuable. We might see that as more suffering, longer death. Do parents have capacity to make that decision? So that's obviously understanding, of course, is going to be sort of basis of that capacity, but there's going to be simple things like parents who have a lower IQ. Is the child involved where possible in that decision making is really important. Somewhat vague, but there's not an unreasonable use of resources. So again, that might be more troublesome for people from low-income countries. And there's not undue harm from the child from the intervention. So I don't think there's anything magic in any of those, but I do think that you can use those just to tick a few boxes and see whether we can manage and acquiesce or legitimately. We don't need to that legitimately go against the parents' wishes. So the paper I talked about in Life Worth Living sort of developed a little bit further, and I think is closely aligned to the zone of parental discretion. That there's not a single line, that there are thresholds about which we might make decisions. And again, when a decision's to be made, it's good to look and say, well, is this obligatory that we go on and offer home ventilation? Or is it obligatory that we don't, because it's very, very clearly harmful to the interests of the child? Or is there something in the middle where basically one set of parents might decide one thing and that's okay, and another set of parents might decide another thing and that's okay? And so here in that, when they're thinking about life's not worth living, possible relational capacity came out as the one thing where it seemed to be that there was strong advocacy for continuing life, and that would include home ventilation, but discretionary at locked in or minimal cognitive function or significant burden, But when there was absolutely no awareness, then perhaps there was less obligation to keep going, perhaps a positive obligation to stop. So what do we do with Samira? Remember, she's 10, not verbal, severe cerebral palsy, lots of admissions. I guess we will try and find out who she is. She goes to school. Before she got sick, 5 days a week. She's had less and less school this year, but she enjoys school, family, together, a couple of siblings. Life seems reasonably normal and jolly at home, as everybody will pretend that their family and life is normal and jolly at home and have a veil of happiness, but it seems to be good. And they have a community of friends, but the school's very much a community for them. We know what a respiratory problem is. Her respiratory pump is just not strong enough. She's probably also got some lung disease from recurrent aspiration, but we can manage that. Can NIV, non-invasive ventilation, help? Probably. Can NIV harm? No, yes. And so what are our options? Do we offer home NIV? Struggle on, which will be, if you remember that trajectory that Avina gave us, lots of recurrent presentations. Do we offer comfort, care? Who's going to decide? Well, I think in this case it's going to be a parent. What's really important is how is that decision made? So that gets back to the shared decision making. So at least in one level, if we think what's our physiological goal, so if we apply non-invasive ventilation, we can improve her ventilation. That might give her consolidated sleep, you never know. Might give her some rest so she's better in the daytime when she's not on ventilation. And it will certainly recruit airways, act a bit like physiotherapy overnight. So that'll solve the problem. And our clinical experience over many, many years is this sort of kid we would rarely see for dust for many years. Once we start NIV and cope with their respiratory infections, certainly much fewer admissions to ICU. Of course, the downside is we get some quality of life now. Later on, perhaps she's on permanent non-invasive ventilation, not able to come off, and then that's a very difficult situation. That's going to be a very, very hard trade-off, but perhaps what we can think about is whether we have a conversation at this point, which is we can help now, but we have to promise each other that if life gets too hard for Samira, that we will acknowledge that and consider stopping our intervention. It's a nice thought, it's a nice way of approaching the problem. I think sometimes that's a little bit of a fantasy, it doesn't always happen like that. But our practical goal is getting home. Home is where the care is, and we can achieve some things that I think will be reasonable values for her prolonging her life, quality, family time. But I think the small downside, sometimes pressure on the face, injury to the nose, sometimes if it's very, very long term, some slightly moon-shaped face, I think that's going to be an issue here. But it seems to me in this case, with willing family, a life to go to, a school to go to, that NIV is appropriate here, recognising we're probably going to have a battle later on. Battle is going to be difficult. Samira's going to have a battle later on when she needs this all the time. I think more difficult is Poppy, who's 18 months, with advancing muscle weakness from Pompey's disease. So she's 18 months, she doesn't go to school, but she lives in a family. She's got siblings, she's got grandparents. Respiratory problem, again, is just poor respiratory pump. Her heart seems to be holding out. Can tracheostomy invasive ventilation help? We'll look at that, yes. Can it harm? Yes. So what do we do? Do we offer a NIV? That really should be tracheostomy and ventilation. Struggle on. Comfort, care, but we know that parents have, well, decided, demanded, insisted, jumped up and down that they want to have a tracheostomy and ventilator. And how was the decision made? I think, well, they're making the decision. We're trying to get involved and support them too. Because I guess what we bring to that shared decision-making is experience. What's life like with a kid with a tracheostomy and a ventilator? And they can't have, this is interesting about informed consent, isn't it? How can they really genuinely have any knowledge of that or understanding of that if they've never been through it? Now, maybe they have a sort of empathic mind that can really imagine it, visualise it, but I don't know. But I lie in bed. We've renovated our house. We had all our kids on the same floor as us rather than upstairs and and downstairs and look across to where my dear little baby Jack's 6'8" and 24 years old, but he's still BJ to me. And imagine him at home on a BiPAP machine, and me with the skills. I couldn't even imagine a tracheostomy, and I would be, okay, I'm Australian. I would be crapping myself every night, looking across and worried and wouldn't sleep. And I know Jenny, some of you met my Jenny, wouldn't sleep at all. But how can they really know? So we know what's the goal here. Well, the tracheostomy would manage the airway, would manage the secretions, reduce aspiration and access for ventilation, big tick. But she'd lose something. Now, she's 18 months, but she might want to try and talk, or if kids are talking, they're not usually after a tracheostomy and a ventilator, and I think that can be a massive loss for older kids, slightly older kids than Poppy. She won't be able to swallow anymore, so feed will definitely all have to be down the nasogastric tube or a PEG. She'll require suction, constant carer in attendance. Well, she's 18 months, she's probably going to have a constant carer, but when she's a little bit older and wants to go to school, that could be really difficult. So our goal might be home, and parents are prepared to face that. We can prolong her life, but she will eventually become locked in. So whose goal is that? The parents will have more time with her, but she may not appreciate that. We have some, it's hard to assess her intellectual function, but it's probably normal to reasonable. So she has the capacity to suffer existentially. She's with a family. Or perhaps we started and we just can't get her home, and then she's stuck in hospital, and that's real concern. I think we can get just about anyone home as long as they're stable. If they're unstable, probably means they'll pass away. But if they're stable, we can get just about anyone home. But maybe what we're doing is prolonging her suffering or prolonging her dying. This theoretical cases, although we face similar things, my sense at the moment is that she's suffering to some extent now from her airway and secretions and hyperventilation. So I think a little bit like Samira, we can offer positive benefit now in terms of tracheostomy and ventilatory support. And I think if there's a reasonable chance that she will actually be able to go home, so the home environment is okay, parents will be able to cope, then I think that to me is an option. I think though the moral disquiet is that we know that she will be likely to be at some stage locked in, and in a sense we're ventilating her and sort of waiting for the heart to give out, which just doesn't really feel like a great plan for her. Now other families might ask for other things there, obviously that's what the family's demanding. So that's how I read that situation today, but we're going to have some discussion, and we'll just come back to, while we have our discussion, just think about this as our cut through, what's in it for the kids. Thank you.